My name is Suliana Shahrin, and I'm an accredited exercise physiologist. As an AAP, I specialize in the clinical exercise interventions for a broad range of pathological populations. In today's video, I'll be discussing the role of exercise management for osteoarthritis, known as OA, the expected effects of OA on exercise participation, and the expected benefits of exercise for OA. Osteoarthritis is one of the leading causes of pain and disability worldwide. The chronic condition presents itself as cartilage degradation and bone remodeling with joint inflammation, pain, and loss of normal joint function. The key point of this presentation is that exercise is recognized as a core treatment and first management option for OA, as research has shown its effectiveness in alleviating pain symptoms and improving function. As seen in this guideline by the Osteoarthritis Research Society International, the non-surgical management of OA involves the core treatment of land and water-based exercise with the focus of strength training and weight management. It is important to note that exercise is advised prior to pharmacological management, regardless of the type of OA and/or presence of comorbidities. The role of exercise for patients with OA is to relieve the common symptoms of joint pain and improve everyday physical function. The ease of application, few adverse effects, and relatively low cost of exercise should be utilized to provide the best treatment for your patient. In order to determine the effects of OA on exercise participation, we must first understand the symptoms associated with the condition. Pain is a major OA symptom involving both peripheral and central neurological mechanisms. The pain of OA is activity-related, with pain coming on generally only when a person does specific activities that induce it. For example, in persons with knee osteoarthritis, walking up and down stairs often produces pain, whereas lying on a bed would not. Osteoarthritis also leads to muscle weakness, reduced postural control, joint instability, and restricted range of motion. As a result of these symptoms, individuals with OA experience difficulty performing daily functional activities, which consequently reduces exercise participation. The current body of evidence supports the use of exercise for the effective treatment and management of OA. Guidelines by Osteoarthritis Research Society International and a systematic review by Uthman et al. Found that exercise interventions involving strength, flexibility, and/or aerobic exercises were more effective at alleviating pain symptoms and improving range of motion and function compared to no exercise controls. These studies also found that a combination of all three exercise modalities proved most effective. Water-based exercises have also been proven to be an effective treatment for pain and self-reported function in patients with OA due to water reducing the load placed on joints. Water-based exercises are particularly appropriate for people unable or unwilling to train effectively on land due to pain. Strength training has also been supported by several studies, including a randomized control trial by George et al., who found that 12 weeks of progressive resistance training lowered pain scores, improved function, quality of life, and increased strength. Lastly, Hernack and Barber established that weight loss led to significant improvement in knee pain, stiffness, and function due to the decreased load on the joint. As such, weight loss can be achieved through exercise in combination with other lifestyle modifications. Despite the large variability in length, frequency, and session duration in OA research, general exercise prescription can be based on guidelines by the American College of Sports Medicine. Aerobic exercises, both water and land-based, should be performed 3 times a week. Strength exercises should be performed 2 to 3 times a week on non-consecutive days, and flexibility exercises should be performed daily. General recommendations for intensity apply, but should be tailored to the individual. For example, starting at 40% of heart rate reserve should be applied to those limited by pain, and 10% 1 rep max should be applied to individuals with severe arthritis. Each exercise should be performed for 10 to 15 repetitions. Programs should start with short bouts of 5 to 10 minutes that accumulate to 20 to 30 minutes a day, with the goal of achieving 150 minutes of moderate physical activity per week. Programs should include aerobic exercises with low joint stress such as walking, cycling, swimming, as well as resistance training and stretching for the major muscle groups. Consideration should be given to comorbidities when prescribing exercise. It is important to be aware of the absolute contraindications and to individualize programs based on the patient. The 30-second sit-to-stand test, the timed up-and-go test, the visual pain analog, and the WOMAC are great assessment tools used to monitor patient progress throughout a program. In conclusion, exercise is the first management and core treatment for OA. There is a strong evidence base supporting its ability to reduce pain and improve function. Strength aerobic and flexibility training should be included in a program to maximize effectiveness. Lastly, exercise programs should be individualized and tailored according to abilities and presence of comorbidities. For more information about the role of exercise in the management of osteoarthritis, check out the following research articles.